Welcome back to Lipid Health Concerns Part 2, mainly talking about cardiovascular disease. In this session, I want to get more into nutrition therapy than we did in the last session. In the last session, we talked some about LDL cholesterol, and we looked at it as being the primary target and why LDL is an issue in cardiovascular disease. And we looked at oxidized LDLs and so forth and so on. But if your patient comes in with a low LDL number, they could still be at high risk if they have metabolic syndrome. So if you remember, metabolic syndrome is if you have high cholesterol, high HDL or low HDL cholesterol, high triglycerides, high blood pressure, and then diabetes could be thrown in there. But you could be just as high a risk with metabolic syndrome as you do LDL cholesterol. But in this session, like I mentioned, I want to look at nutrition therapy and look at what could raise LDLs in food and what could lower HDLs in food. So I want to start with long-chain saturated and trans fatty acids because these are considered the ones with the highest risk. And there's two reasons I want you to remember. One is that they do impair the liver receptor pathway. Remember, the liver cell has LDL receptors, and they can make them or take them away as they need to, or as affected by saturated or trans fatty acids. And if you lower your receptors, then you're not going to be able to take as much LDL out. If your LDL stays high, then there is an increased risk of them being oxidized and going the scavenger pathway, and increasing risk of cardiovascular disease. So there is some research that says that saturated fats that are 14 to 16 carbon lengths are the worst of the saturated fats. We'll show some exceptions, but there's a recommendation to lower that below the 10% goal down to 7%. The one foods that have the highest 14 to 16 carbon are your milk fats. But again, don't feel lost. We will look at those a little bit later and show that they may not be, depending on the food, may not be bad. And then reduce your trans fats. Now, the World Health Organization wants to get all of trans fats out of all foods by 2023. Whether that's going to happen or not is an issue because you've got to have a substitute. And as of yet, there hasn't been shown a good substitute that is inexpensive and will not affect the flavor of the food, will not affect the texture of the food, so forth and so on. So until they find a good substitute, either you're going to pay more or it's going to taste different. But they're working hard. There's a lot of research going on how we can decrease our trans fats. So this diagram, if you remember, we looked at high LDLs in the blood, and then they're taken into the liver cell and are deesterified and become free cholesterol. We also looked at the ACAT pathway that is going to re-esterify the free cholesterol and store them or put them basically in a VLDL and get rid of them. But as you can see along the side there, the ACAT pathway have an X through it, which basically means you inhibit that ability by the long chain saturated fatty acids and trans fatty acids. So if you inhibit the ACAT pathway, you're going to have less effectiveness of changing free cholesterol into esterified, therefore increasing your risk, because you will continue to have an oversupply, which will inhibit the ability, transcription, translation, the ability to make liver cell receptors and LDL receptors. And if you don't make LDL receptors, then you're not going to take LDLs into the blood and they're going to stay high. So the misconception by a lot of consumers is that saturated fats or trans fatty acids will cause your body to increase LDLs, and that's not true. What they do is they just reduce the ability of the liver to take them out of your blood, so therefore they are high. So in any case, it doesn't matter, I suppose. your blood LDLs are going to be high, and therefore increased risk of oxidation, increased risk of scavenger pathway, chronic inflammation, so forth and so on. So the goal is to reduce long-chain saturated fats and trans fatty acids. And these are the foods that are high in saturated fats and trans fats. You can see saturated fats are high in animal products. Trans fats are in processed foods. But hold on a minute. There is some hope for you that eat foods with saturated fats. There was a study done by the Dairy Council that compared butter to whipping cream. So both of those products are packaged or produced a little bit differently. And so the fat is packaged differently, and so it has a different structure and has a different functionality. So they compared looking at the same amount of whipping cream to butter oil and butter, and its effect on LDLs, HDLs, and triglycerides. You can see at the bottom of that graph. And what you can see is they found that butter increases LDLs, decreases HDLs, and increases triglycerides a lot more than whipping cream. So even though they're both dairy fats, they are both different in their structure and functionality. Therefore, their risk is different. So anyway, another issue is cheeses. They found that hard cheeses versus butter, hard cheeses didn't have as much effect on the cardiovascular disease risk factors as butter does. And you can see down there at the conclusion, it's basically because it's been fermented, and there's some changes that are done to the fat and some additional products that are made. Another aspect of fermented foods you can see is fermented foods are considered very healthy, and there's some evidence to verify that. Even though yogurt's made from dairy fats, has dairy fats in it, the fermentation process is going to make it a lot more healthier and safer to eat. One of the things that's come out of this research on fermented foods is a term that's referred to as postbiotics. Now, we've discussed prebiotics, if you remember. So those are foods that you eat to increase the probiotics in your gut. And then probiotic foods have live living cultures. But postbiotics are foods that have been fermented where the bacteria have produced basically their waste products, but have produced products that are considered healthy. And they have benefits to the gut and benefits to us, the host. And you can see on this little diagram at the very bottom, kind of just a beginning list of postbiotics that are made by bacteria during fermentation, and their local effects on the gut, and then once they get through the intestinal lining, what their positive effects are inside the body. So postbiotics is going to be something you're probably going to hear more about. It's still kind of in the infancy stage, so I wouldn't take this as gospel or carved in stone. There's some research that these postbiotic products are a benefit to the health of the host, but it's not for sure yet. So just keep that in mind. And there's a lot of studies on kefir and yogurt and things like that. But more to come. With that in mind, the Canadian Heart and Stroke Foundation has basically reduced its limits on saturated fat. So what they're saying, as you can see in the left hand where it's underlined, the evidence saturated fat could be different depending on how it's packaged or produced. So they've taken all the limits off, so they don't say you need to reduce to 10% of your diet or 7% or something like that. They mostly are concerned with the type of food that you're eating that has the saturated fat in it. So that may be the future. The U.S. government hasn't quite adapted that yet, but it's a possibility that they could recommend, cheese is fine even though it has high saturated fat. But as of now, the recommendation is still the 10% goal. All right. Now, monounsaturated fats are considered heart friendly because they don't affect the liver receptors. They don't increase the scavenger pathway. They only have one double bond, so they have a very low risk of oxidation, so they don't increase the risk of chronic inflammation or anything like that. So there is a call to possibly increase the recommendation to 15%. But I'm kind of like the Canadians. I think we should be looking at food and not individual nutrients, that kind of thing. So here's the foods that have monounsaturates in them. So avocados, olives, olive oil, they're all considered heart friendly, so lots of nuts, things like that. But you have to remember there's still 9 calories per gram. So if you eat too much, you're going to gain weight. But the recommendation is, if you're going to use fats, monounsaturated fats would be a good choice for you to use. Omega-3s are considered heart friendly because they also do not affect the LDL receptors on the liver cells. They have an effect of decreasing blood clotting, which is a good thing if you're at risk for heart disease. But I might put a caveat on there is that if you're on blood thinners like Coumadin or something like that, you don't want to take a lot of omega-3. You would not want to take supplements because that would thin your blood even more. So you don't want to do that. So if you have a person in your life that is taking Coumadin or something, you would not recommend they take omega-3 supplements. They can take omega-3s, but not in excess as a supplement. They have a reduced ability to be oxidized, omega-3s, so they're anti-inflammatory, which is a good thing. So you can see the goals. Now, if you're buying supplements, you want to look carefully if you're getting fish oil supplements or something like that. The recommendation is take about 1 gram a day. So that would be, a combination of DHA and EPA. But you have to look carefully because there's some fish oil pills. I've been to Costco and kind of looked at the different products. And you have to be careful because some of them say, 1 gram or 1,000 milligrams supplements. But if you look at the EPA and DHA, they're very low. They're like 100 or 200. And the rest is just fish oil, that doesn't have the benefits of DHA and EPA. So you want to look on the label, make sure you're getting, they're not going to be even, but make sure you're getting like 600 EPA, 400 DHA or something like that, so that they add up to 1,000. Or eat fatty fish 2 times a week, and we've discussed what fatty fish are, that kind of thing. Omega-6s, they are not considered heart friendly. It's not because they, excuse me, it's not because they affect the LDL receptors. It's because they are pro-inflammatory. they increase chronic inflammation. They increase the scavenger pathway, which we don't want. Increases blood clotting, which you don't want, and they have an increased risk of oxidation. So that leads to oxidized LDLs at a higher risk. Goal, reduce to below 10%, and maintain a good ratio of omega-6 to omega-3. As you can see at present, the most of the data I see is about 30 to 1. Well, we want to be 2 to 1 because we're eating a lot more omega-6 food products than we are omega-3s. So we've got to try to get that down. Here's the relationship between inflammation. You can see omega-6 when you eat them are broken down to arachidonic acid, and then they become pro-inflammatory products. Omega-3s broken down to EPA, and they are anti-inflammatory. So we need to reduce our omega-6 foods. On the left, you can see the foods that are high on omega-3. We went over these before, but fish, fatty fish, walnuts, chia seeds, flax seeds, I'm not sure why pasteurized eggs, I mean pasture-raised eggs, but probably because they eat grass instead of just the feed, I would guess. Omega-6, you can see, we've talked about it, vegetable and seed oil, so safflower oil, corn oil, sunflower oil, mayonnaise that's made with corn oil or something like that, and the other ones. So not all seeds, you can see chia seeds and flax seeds are on the omega-3, but other seeds, corn oil, safflower oil, corn seeds, that kind of thing. We need to reduce these down and increase our omega-3s. So in cooking, it would best to use canola oil or olive oil. And you could use other oils, walnut oil if you want, for occasionally, but those should be the best. And here's the reason why. You can see down in here where soybeans 51%, but omega-3, but canola is 20% omega-6 and 9%. It's kind of almost a 2-to-1, that kind of thing. But that's the best one for the omega-3, omega-6 package. But olive oils, remember, is high in monounsaturates. So for your cooking oil, you should choose canola or olive oil, and then walnut oil or something else on occasion. You have to be careful with advertising. Smart Balance is advertised to support healthy cholesterol, but if you look at the fine print that I've got bold, it says yes, but the tiny print says already in the if it's already in the normal range. So it supports healthy cholesterol if your cholesterol is in the normal range already. So it's not going to take a high cholesterol and help reduce it. And then it says that it will improve your cholesterol ratio if you eat at least 2/3 of your fat intake being Smart Balance. So, I mean, who's going to eat 2/3 of their fat intake from Smart Balance? Not very many people. So be careful. Advertisers are very smart, and make sure you read the labels carefully. Okay, so that's for LDLs. So they're the ones that we want to get as low as possible, below 100. HDLs, we want to get above that 45 number. And the top 3 purposes is the only ones I want you to remember. HDLs can reverse cholesterol transport. I'll show you that in a second. It's antioxidant. I can show you that. And it's anti-inflammatory. So those are 3 big good things about HDLs. As far as how do you raise HDLs, there's really no food that's going to raise your HDLs very significantly. I mean, it all helps, but the main thing that's going to help raise your HDLs is aerobic exercise. However, there's a caveat to that one. If you are exercising a lot now and you are really fit, but your HDLs are low, you are not going to benefit too much by exercising more. Okay. If you have a low HDL and you don't exercise at all or very little, aerobic exercise is going to help a lot. Okay. I remember when I was doing a panel in Vancouver, city of Vancouver, where it was I was doing the interpretation of LDLs and telling what they are and stuff, and then we had a lab person who worked in the lab who actually did the testing process and he explained how they tested for LDL, how they tested for total cholesterol and that kind of thing. Well, he was a marathon runner. He ran at least 100 miles a week, and he was a beanpole, looked like a runner, but he could not get his HDLs above 42. Didn't matter what he did, he couldn't get them above 42. So in his case, you know, running 150 miles a week wasn't going to help him any, really. But in all reality, he wasn't at very high risk anyway because he was in very good shape. So that would be the caveat, is that if you don't exercise, HDLs are low, then you might start doing some aerobic exercise. Losing weight, stop smoking, decrease trans fats, decrease alcohol is going to help a little. I mean, all of those combined, if you need to, if that's in your life, is going to help. And the combination is going to help a little. And but aerobic exercise is the key one. So here's the deal with oxidation, CEPT and ETP. You don't really need to know that, but you can see that the first sentence, CETP transfers oxidized lipids from LDL to cholesterol. So what that means is oxidized lipids within the LDL can be removed by this transferase transfer protein from the LDL to the HDL, and then it got rid of it. So you reduce the amount of oxidized lipids within the LDL. Okay, so that is going to reduce the risk of the scavenger pathway. Anyway, so I'll give you a little figure on that. So you can see the CEPT, I can't even say it, CEPT highlighted, and you can see where it's pointing is that you have LDL, the stars are the cholesterol. So you can have the LDL, and you can see that the stars are being transferred from the LDL to the HDL, plus the little dark marker thing is the oxidized LDL, and you can see that the oxidized is also being removed. Okay, so in that sense, the reverse cholesterol transport HDL can remove oxidation from the LDL. The other one is this peroxidase, and it is one that will deoxidize LDLs and also remove LDLs oxidized from the foam cells. So that's a positive. So if you look at the left-hand bottom corner, you see the red box. You see HDL in the green and the peroxidase. You can see there's an oxidized LDL on the right in the red, and you can see it's changed from an ox LDL to a regular LDL. So HDL in that case is an antioxidant, and it's going to reduce the risk, because remember, LDLs, if they're not oxidized, will not be gobbled up by a macrophage. Macrophages gobble up things that are foreign. So an oxidized LDL is foreign, a regular LDL is not. And so if your HDL peroxidase can deoxidize it and make it normal, then it's not going to go in a macrophage. Then you can also see on the right-hand side, the peroxidase is taking LDLs and oxidation from the foam cell. And so it is going to reduce the size of that foam cell, reduce the amount of products within it. And so that would reduce the amount of plaque that's going to be produced. All right. You can read this at your leisure, but you can see it's from obesity. And what it says is, you see the third line down, HDL from obese patients repaired less efficiently. So HDLs are different. And obese patients, they seem to have a less effective HDL for reverse transport and antioxidant activity than from non-obese patients. So if you're an obese patient, you have an IHDL, that may be good, it may not be good, because maybe your HDLs are not as efficient as they should be. So another reason that obesity, even though your numbers look good, the efficiency may not be good, so you need to lose that weight. Just to look at some possible future testing, I ran across an article that looked at HDLs. Right now, we only test for total HDLs. And as you remember, I've shown this graphic before. We have different sizes of LDLs. We also have different sizes of HDLs. So you can see on the bottom right, left corner, there's 5 different sizes of HDLs. I'm not sure if that's all of them, but in this graphic, that's how many. They all have a different particle number, like you can see HDL2B, that kind of thing. They're all different sizes. So the possibility in the future, and there's some research going on this, is that they will be testing for the type of HDL you have, because different types of HDL have different HDL functionality. Some of them reverse cholesterol transport very effectively, some do not. So it could be that people have high HDLs, but they have not the good kind, right? They aren't able to reverse cholesterol very efficiently. So they may also be testing for the HDL particle number, so 2B, 2A, something like that. Now again, this is not done yet, but it's a future possibility, because just like we used to think in the old days, total cholesterol was the big number. Now we know it's not, because we have LDLs, VLDLs, HDLs, IDLs, chylomicrons, all part of the total cholesterol package. And the same now in the future with LDLs. They're looking at small dense LDLs, buoyant LDLs, that kind of thing. And in the future, they're just now getting into looking at the different sizes of HDL. So maybe a test someday for the type of HDL that you have. There's always been an issue ever since I started studying nutrition with red meat, since the late 70s. And it's always been a risk factor, and multiple studies have shown that red meat was a risk factor. But it's always been thought that it was the saturated fat, because if it's an animal fat in the beef, then it would be saturated. And it's always been thought that the saturated fat was the problem. Well, it may not be, because if you remember, the carbon links of long-chain saturated fatty acids 14 to 16 are the highest risk, potentially. The carbon links in beef are 12 carbons, mostly. 12 carbon links have not been shown to be that high of a risk factor for cardiovascular disease. Well, the next thought is maybe it's the iron in the meat, because they have found that iron is cardiotoxic. So the concerns are for when you don't need as much iron. If you're a man, you don't need as much iron as childbearing women. If you're postmenopausal, you're more like a man. In this case, in that you don't need the amount of iron you used to. Too much iron is referred to as iron overload. It can be cardiotoxic, and it's stored in heart cells as ferritin. If you get too much, it can be toxic, and it can be a free radical. So a free radical then could increase the risk of inflammation. It could be increase the risk of oxidation. So not a good thing. If you look at supplements for over 50, if you get a good supplement, it will not have iron as one of the minerals in the supplement because of this concern. So if you know somebody that's taking a vitamin mineral supplement and they're over 50, have them check it and make sure there's no iron in there. Okay. That's also a concern with bread. If you notice that what they add to bread, they add B vitamins and iron. So there is some concern that if people over 50 eating a lot of bread products that are fortified, then that could be increasing their risk for cardiovascular disease. So there is some push to potentially take iron out, but why was it put in there in the first place? Because most women are deficiency or they're anemic, so they have iron deficiency anemia. So they put it in bread to make sure they get it. But that may be a harm to people over 50. So nutrition goes on. All right. And here's some evidence from the British Medical Journal that basically is talking about that. People who eat the most beef and other red meat have higher mortality, and then I highlight in red they singled out the iron in the meat, and the nitrates and nitrates are the likely culprits. So it's not potentially not the saturated fat, but the iron in the meat that's the risk factor. And here I talked about ferritin, so you can see ferritin carries iron and it stores it in the cells and can become toxic. And here's the deal with peroxidation. You can see that Fe+2 could act as a free radical. And if the vitamin E is there as an antioxidant, but if you don't have the vitamin E, it could lead to lipid peroxidation and cell death and become cardiotoxic. Okay. All right, so that's it for this session. We'll talk to you later.